With me today is Dr. Angela Genge, Kelly Goodman, Dr. Cinda Driss, and Melissa Diaz Vieira. I want to emphasize that this is completely interactive, so if anybody has a question, please feel free to walk up to the microphone. If you can't get there, please raise your hand. We can get you a microphone. And virtually, you can enter those questions in the chat. So without further ado, oh, yes.
Do we know where the chat is? Because it was over there, but I don't see it now.
Oh.
Do we have the, somebody is, are you? Chat. Yeah. You're managing the chat?
I guess so.
Okay.
Thank you, Dr. Kelb. So without further ado, thank you, Dr. Driss, for that. I think we can just start by, if you all wouldn't mind discussing a little bit about yourself and your connection to ALS.
You can start.
Okay. Hi, everyone. My name is Melissa Diaz Vieira, and I was diagnosed with ALS in February of 2023. So for me, my symptoms started in October of 2022. I noticed that my pincher grasp was getting weaker in both hands, and that my thighs had kind of started twitching unusually when I would lay down at night. At the time, I was the exhausted mom of an 8-month-old baby. I had just had a pretty rough bout of COVID, and I was dealing with some life stressors, so I gave it some time to see if my symptoms would subside. But by January of 2023, I noticed I could no longer use chopsticks. I was having more trouble buttoning my baby's clothes and even zipping my own pants. So I made an appointment with my primary doctor and had a physical. She ran some blood tests, an autoimmune panel, and she decided to also send me to do an EMG. She said she wanted to make sure my brain and my muscles were communicating with each other through my nerves. Well, a few weeks later, I went for that EMG, and it came back abnormal, shockingly. They found that I had denervation in multiple areas of my body, and that led to an emergency neuro referral. 2 days later, I was diagnosed with ALS and told I had 2 to 5 years to live. So it was absolutely shocking to me, very devastating, and overwhelming. So the last 2 years have been quite a journey for me. As I sit in front of you today, I am wheelchair bound. I just lost my ability to walk just this summer after one of several falls this year. I've lost quite a bit of function in my arms and hands. Although I can still use them, I do need help for most of my daily tasks. I'm lucky to be able to maintain my speech and my swallowing so far, and that I'm managing my breathing well with the help of our amazing pulmonologist that we were talking about earlier. So, the way that I've decided to tackle this disease was to kind of do what I do with most things in my life, which is just kind of go all in. So I decided to learn as much as possible about ALS and try and understand this very complex and mysterious disease without zero neurology background. I also tried to really connect with our community, which is an amazing one. And through those efforts, I've now joined Her ALS Story, which is a group of young women diagnosed with ALS. We try and raise awareness about the diversity within the ALS population, so that people understand this is not a disease that only affects older white males. I am a young Puerto Rican woman. If I can be diagnosed, so can anybody else. I've also had the opportunity to work with Project ALS, a wonderful organization that funds preclinical research in the ALS realm. And I've recently joined the support services team here at Les Turner Foundation to ensure that we are giving the best care possible to our ALS patients. I'm really happy to be here today, and I want to thank everybody who's come and taken an interest in ALS and all of your efforts to find effective treatments and a cure. Thank you.
Okay. Hello, everybody. I'm Dr. Driss. You guys heard about me a little bit earlier. I've been working with ALS patients for now 20 years. I'm not saying my age. You have not heard that. It is really a privilege to be trying to help our patient in not only to do the clinical care, but also to be involved in clinical trials. I'm happy to be here, and I'll try and answer whatever question you throw at me.
Hi, everyone. My name is Kelly Goodman. My husband, Jason Goodman, was diagnosed with ALS in 2017 at the age of 45. At the time, our children were 12 and 15 years old. We both were working full-time. He started having some muscle weakness like in 2015 and was actually like misdiagnosed for about a year and a half. And in February of 2017, we were introduced to Dr. Driss, and she confirmed his diagnosis. And he was treated here at the Les Turner ALS Clinic and Center, and with Dr. Coleman as well as his pulmonologist. He had the sporadic version of ALS. It was slower progressing. He was able to run a marathon right before his diagnosis and shortly after his diagnosis. And then in 2019, he really started to lose a lot of functionality with his legs and then was more chair-bound or wheelchair-bound. So fortunately, I was working full-time, so I was his primary caregiver. Our children helped as much as they could. Shout out to my daughter over there, raise your hand. But no, really, I can't thank the clinic enough for all that they did for us and our family, and how we can talk about that later if that comes up. But Jason passed away in March 11th, 2023, 2 weeks before his 52nd birthday. And he really did well until like that last month. He was able to talk and communicate with us. COVID was actually like, there was a silver lining to COVID. It was that we were all able to be home and take care of him and spend as much time with him as possible. And so I thank all of you for your support and your advocacy and being here with all of us to learn more to make this a livable disease. Thank you.
And you've just met me, so I don't need to say anything more.
It's totally fine. But I will maybe put you on the spot a little bit. We just heard some incredible information on clinical trials. Dr. Genge, do you mind further explaining all the different types of clinical research that people living with ALS can participate in?
Okay. So I really focused on what we call interventional clinical research, right? So clinical trials are really talking about having ALS and taking some sort of treatment. It doesn't have to be a drug, but an intervention with the purpose of changing the course of the disease. There are other forms of clinical research that are super valuable. One is actually just some of our biomarker and our longitudinal studies. So longitudinal is literally that. It's taking samples or doing tests over a period of time, frequency. And that's really important because we would like to get away from doing placebo arms in clinical trials. And so if we have enough data of what normally happens with ALS, we can start to really get somewhere about replacing those placebo arms by avatars or digital twins or some of this new AI-generated work where you can have a fake patient, an AI-generated patient, rather than having a real person go on a placebo. So that's one, the longitudinal research does that. There's also work on the fundamental sides that patients can contribute to, either through contributing blood or doing MRIs or a series of different things. All of that is part of clinical research. And then we talk a lot to patients about once they pass, whether they will agree to an autopsy program, because that information is so important to what we're doing. It's important if you're in a clinical trial and you pass, and because it gives us some information on whether the drug is actually getting to where we think we're getting to, right? But the value is enormous, and I'm humbled by how often a family or a patient who will consent in advance will agree to an autopsy. It's just adding so much to what we know.
Perfectly put. And now, Melissa and Kelly, do you mind sharing your experiences with clinical research? How did you guys know that that was a route that you wanted to take or that it was the right path for you? And maybe where did you turn or where did you get information on clinical trials?
Sure. So my diagnosis process was pretty unusual. I was diagnosed very early in my disease progression and very quickly. And I learned that for a lot of clinical trials, you have to be within 2 or 3 years of symptom onset. And so I knew that I wanted to try right away, especially as a patient that had just been diagnosed with very little FDA-approved options. I saw clinical trials as my only hope, maybe, to maybe try an intervention that could slow my disease progression. So I knew that I was interested in that right away. Where I was originally diagnosed, it was not a research hospital. And so when I first asked, I was just kind of given a link to explore options on my own and not too much guidance. So I knew right away I wanted to, be able to be connected to a research hospital. So that's how I ended up in the care of Dr. Dress. And I also, connected with Dr. Sokovitz at Mass General Hospital as well to learn more about the Healy platform trial. So I tried to just go directly to the source and really get my questions answered. This week actually is my 1-year anniversary from being on regimen F. So I started that last year in November. And so I've completed the 6-month placebo control portion, and I've now completed 6 months of the
Active.
Open-label.
yes, open label extension. I'm like, OLE, what does that stand for? Okay, so yes. So it's been an interesting journey. I'm glad that I've been able to contribute to research in that way. I've also participated in an observational study last fall before I started the Healy trial, and I did that at NIH, and so I traveled there and underwent multiple MRIs, cognitive testing, lumbar punctures, blood work, speech and language testing. So quite extensive, but that was a really great experience as well, and I learned a lot. They also did a full genome sequencing, which was really helpful. But yeah, I think I knew right away that that was something I wanted to do, but it is something that I would advise ALS patients to really think about, and just that it's a really personal decision in terms of what they can handle. Also, the type of intervention can make a big difference. I'm taking an oral medication that I can take at home versus doing something intrathecally where you have to go into the clinic, maybe have more potential side effects or more appointments, et cetera. So just different things to keep in mind.
No, I think you hit on so many important aspects to the really personalized decision behind participating in clinical research. Kelly, how did you and Jason come to that decision?
Yeah, Jason really wanted to participate if there was something available. And fortunately, there was an ALS research study that he participated in. And he also participated in Answer ALS, where he'd answer questions and symptoms, exactly kind of like what you discussed earlier. It's really, like Melissa said, each patient's, comfort level, like how much they want to commute. Will they have a caregiver with them at each visit to help them get there? And because the commitment could be longer, it could be more than what your, quarterly appointments are with the clinic. So you'd be going down, they were long days. We live in Northern Illinois, and so it could be like an 8-hour day. You drive down, you park, you get in the wheelchair, and you see everyone from the research team to the clinical team. So they were, long appointments, but he always felt, and I agreed with him, obviously, is if it's not going to help him, hopefully it'll help somebody else that has ALS or the future patients, because, it's just it's so important, the science, to discover, even if it's a drug that doesn't end up helping, then we can move forward with something else. So that was our view on it.
And I think that brings in a nice point that was brought up, I believe, this morning, or maybe when Dr. Driss was saying, when we were sitting on that call with Biogen, we got these, really upsetting results of a study, but realizing that, okay, maybe it didn't work, but now we know there's something, we don't need to go down that route per se. Or maybe it is, just looking at different outcomes. Maybe it needs to be longer. Yeah, Dr.
I just want to
Driss.
make sure that everybody understands that really in ALS, there is no negative trial.
Yes.
Every single trial teaches so much. And that's how we're here because of maybe the failures that we had before. We learned so much in the past 20 years. So no trial is truly necessarily negative.
I don't know if there's any speech pathologists in the room, but that's always what we said about swallow studies. You can't fail a swallow study, right? It's just an x-ray. You either, you can't fail an x-ray, right? You either have a broken bone or you don't, or you either have difficulty swallowing or you don't. So I love that. There's no bad or there's no failure in a study. Melissa, you are a clinical research ambassador through NEALS, correct?
Yes.
Do you mind telling us a little bit about your experience and how having people living with ALS, directly interacting with people, drug developers, building different awareness, different funding, different clinical design. Do you mind kind of going into that a little bit?
Sure. So when you're becoming a research ambassador, one of the main parts of the training is called the Clinical Research Learning Institute. And, I feel like a big part of that is really teaching people living with ALS, their caregivers, and others interested in receiving this training on how to be like responsible consumers of research. Because sometimes we have these these headlines like this groundbreaking discovery is taking us, leaps and bounds towards a cure, things like that. And, obviously as an ALS patient or family member, you're going to get excited, right? But they really taught us how to look a little bit deeper into these studies, really analyze the designs a bit further, and kind of look at the warning signs that maybe tell us that there may be some holes in those studies. So that we can get excited about the studies that were done really well, right? And so I think that was really important, and just having that awareness is really important work that they're doing. In terms of how people with ALS being involved, I think, there's so many different ways that people with ALS are being involved now, even in terms of design and advocating for different things. I know Dr. Genge, spoke about so many things in terms of inclusionary and exclusionary criteria. I think one that I hear about a lot is sort of the one that I spoke about earlier of having the disease onset being within 2-3 years. And, I'm not sure personally if that's the best indicator of survival or disease progression, right? I can think of people I know with ALS who passed within, less than a year of diagnosis, and then I have a friend who was diagnosed 10 years ago, and she just completed the NYC Marathon yesterday, and it's her 58th one. So I think, it's just a very interesting disease. So I agree that having, better ways of measuring and maybe having different subgroups can really help to have just better data. So I love the conversations that are happening and how people with ALS trying to kind of bridge the gap between people doing the research and those who are actually living with it, and also how our experiences are going through the trials, what we experience when drugs, are pulled off the market, or when, we're seeing trials not succeed, and it can get very confusing and very disheartening. So I think having that connection to real life experience of ALS patients is always key.
I was on a call, and a company that was trying to design a study, we had brought up, if you have money in your budget to comp people for parking or for traveling, and that was like mind blowing. And they were like, Well, why would that be difficult? So I think that's why people with lived experience need to be in that room, just to bring up those very real daily parts of your life, and then how drug developers can then redesign or think a little bit differently about their study.
Can I clarify one
please do.
thing
Yeah.
really quickly? So I just want to make sure that if we say that the inclusion criteria, you need to have patient within 2 years or within three years, that means it's from the diagnosis. So they have that time. And we do that because we really don't have a good way to know if the disease is really active or no. Because if the disease is no longer active, you may not be able to change anything. And so I could see how, like in the future, if we have a way, a more objective way to show that really the disease is active, it doesn't matter. Maybe it's active in patient who had disease for even 5 years. That is the difference.
That's a really, really important point. And I think it leads nicely to my next question. 2024 was a little slow for clinical trials, or that might be the perception to some of us in the room. But Dr. Driss and Dr. Genge, what can we look forward to in 2025? What are some things that you're really excited about?
So I don't think it was slow.
Yeah, please. Yeah.
We had a number of results that came out negative, at least in the trials that were run. And there's lots of background work being done to see if there's subpopulations in a couple of the trials that actually responded. We learned a lot about our ability to we learned a lot about how robust that tofersen result is, because the other two programs coming out of Biogen, one had their NFL went up, and the other one, the biomarker only improved by 20%, and it didn't lead to a big robust response. So we're learning how much we have to move neurofilament to correlate with clinical. We're learning that we probably should know if any patient going into a trial is set up for success. And we have, I can think of a half a dozen new trials coming. So it's not that there's nothing going on. It's simply that the learning wasn't an overwhelmingly positive set of results. And the other thing to really understand is the pushback when that first top-line result came out with tofersen was because what we had experienced in clinic was not what they were presenting from the top-line results, which is why I blame the statisticians, because they're an easy target. And we're learning more and more and more, right? So there's a publication coming soon out of the Miracal study, which is in something called an IL-2 target, and they're learning some very specific things about who responded and who didn't. So all of that's really, really important.
So I think that just kind of you might have blown up my brain a little bit.
Okay.
Just now. So maybe we're comparing apples to oranges, and we shouldn't necessarily be comparing the speed in which research is coming down in 2024 from 2023, right? Or 2022. That they really are in and of themselves, like very specific.
Yeah.
That was kind of how I took that. So that's really, thank you for explaining that a little bit better.
Being more optimistic.
Yeah.
Well, I
we
mean,
all love that.
Something to look forward to in 2025 is hopefully in the beginning is going to be the readout of the regimen F and G of the platform trial.
Yes.
So we're waiting for that, really, really kind of hoping, like, so something, we're hoping for a good either Christmas present or a New Year present. We'll see. So we're excited about that.
Yeah. New year, new ALS or something like that.
Yep.
Hande, I think there are some questions in the chat.
Yes, if you allow me.
Yeah, please.
Some friends living with ALS, they have some questions. And one of them says, usually the slow progressors are not included in clinical trials. And the person asks, what must we do to include slow progressors, because they may be telling something important about the disease as well? And what can be done to include them in clinical trials? So that's question one. And then the second question is for Dr. Genge. And this person says, you are brilliant and invaluable. If you yourself was diagnosed with ALS, how would you determine which treatment strategy or regimen would be adaptable for yourself? What path would you take? So there are two questions.
So the slow progressors, it's a really good question, because it's the inverse of what we do, right? So what we do is look for the earlier patients, and we're trying to concentrate on normal to fast progressors because we want to see a signal quickly. And we are theorizing that patients who have a fast progressing disease will have an earlier response. That may not be true. When you look at the converse, slow progressors may have an even bigger benefit from very specific therapies than anyone else. And that one of those caveats is these genetically determined forms. If you correct for SOD1 or FUS in a slow progressor, you may be having a dramatic effect on their lifespan. Our challenge is how to interpret those slow progressors. And this sort of avoidance of slow progressors came out of studies in the teens, 2014, 2015, where too many slow progressors, in retrospect, got into the placebo arm. So it looked like the placebo patients were responding, but it turned out to be an imbalance of slow progressors in one arm to the other. So it could be that what we do eventually is learn how to just balance the arms. And that way we can include both fast, normal, and slow progressors. The question about what I would do, boy, it's interesting because, I've had friends who've developed ALS. I have colleagues who ran ALS clinics who developed ALS. So, it's actually that close to us. Well, first thing I do is get my genotype done, 100%. And then I would look and see, and then I'd probably think about whether I'm mostly lower motor neuron, so twitching everywhere, or mostly upper motor neuron, because I think that that's another feature that would determine which kind of treatment you'd go on. And then I'd hope like hell some of the new treatments are effective. But I'd be lining up to get everything done like yesterday or tomorrow, right? Because the evidence is that the earlier you are on a therapy that's effective, the more effective that therapy can be.
I just want to put a plug there to the importance of early diagnosis.
All right, I'll bring it back to conversation here. Dr. Driss, Dr. Genge, what can you tell us about what's changing regarding kind of the speed of drug development? I know oftentimes we talk about obstacles, oftentimes that's money, but are there any other obstacles that you could identify or anything that we can do in the room or watching virtually to kind of break down some of those barriers?
I think you've heard it today. The most important thing is to develop biomarkers so we can speed drug development. And the way to develop biomarker is to really do good natural history studies. Yeah. And really not just ALS patient, but ALS patient, other phenotypes, and really healthy control as well. So this is a plea. If you're out there, you want to help the ALS field, you don't have disease, there is a place for you too. It's very important to know what happens in the healthy control so we can compare them to the ALS patient. They may involve giving spinal fluid, they may involve giving blood, but that's really valuable. And if we have that information, if we have the biomarker, I think we're gonna get to the cancer because that's how they sped up the drug development. I don't necessarily think it's about resources, it's mainly about that.
And that's a big part of all ALS,
That is
right?
correct, yes. Yes, there are all ALS that is very interesting, is gonna start. It involves, actually target ALS as well, involves both the controls and the patient with ALS, and also patients who are healthy but carry a gene. We call them the pre-symptomatic or at-risk carriers. They also will give us a lot of information on understanding how, if they're gonna convert, what are the things that happened before. So maybe we'll be able to diagnose this disease even before, or can you imagine? I mean, we could do that with colon cancer. Maybe there'll be a blood test where we know you get your blood test, there are certain markers that'll be there and will help us diagnose it even before. Dr. Ganj said it, it's all about timing. It's how early we intervene. You know, by the time patients come to us within a year of their diagnosis, if their strength is already like 4 out of 5, the number of motor neurons there that are left are very minimal, and that is the problem why we're not able to show any benefit with the drug. So we have to intervene earlier.
Switching gears a little bit, this question is for everyone here. How has the Les Turner ALS Foundation helped you, whether it's through the multidisciplinary clinic, our educational materials, our phenomenal support services team, or even kind of the infrastructure that we have for supporting clinical research? How has it been a benefit?
Kelly, maybe?
Sure, I can go, yeah. Really, we were so fortunate to live close to the Northwestern ALS Clinic, improving a patient's quality of life with having all the multidisciplinary clinicians there. I mean, we couldn't ask for a better place to be treated and to really have the care and the support from the Les Turner Clinic. They not only were wonderful with Jason, but they treat the whole family. So we had access to, social workers. After Jason passed, I joined a bereavement group, headed by Easton. I mean, it's really priceless is the word, invaluable. I mean, again, like we had Karen, our nurse, she was able to secure like a lift chair for Jason to help him get in and out of the chair and connect us with other organizations to help our children, like Live Like Lou Foundation, getting them, into like applying for scholarships and things like that, and grants. I mean, so there's so many connections from the clinic that you can be a part of, and other foundations that help in other ways, right? Because each clinic or each foundation, they don't like monopolize or cannibalize one another. They all have their focus. And so I think getting us those connections was really invaluable. Yeah, definitely.
Melissa?
Yeah, I mean, I agree. I mean, I've found the team, whether the clinic team or the support services team, to be very supportive. I mentioned when I was diagnosed, I was kind of told, okay, you have 2 to 5 years to live, right? And I definitely feel that since I came here, I will embarrass Dr. Driss a little bit because she's very humble, but I feel like she always sees me as a human and not my disease, and she's never given me an expiration date, and that goes for the rest of the team, and that goes a long way. And I also have Karen as my support services coordinator. Shout out to Karen, she's not here today, but we love her. And whether it's in practical ways or even supporting emotionally, she has been wonderful, and makes you feel like family. So it feels good to feel like there are people on your team when you're dealing with something like this.
I think one thing that we have always tried to hone in on is that you don't have to do this alone, right? And, once you're a part of a family, you're always a part of the family. Kelly knows that. Okay, so kind of to wrap things up a little bit, one last question. If there's one message or one call to action that you'd like the audience to take away from all of this, regarding the future of ALS care, research, community support. What would you want them to take away? And this could be anybody.
Well, I would say don't give up on hope. Really, there's and just to support and advocate as much as you can, because when Jason was diagnosed, I didn't do a ton of research myself. I was kind of focused on keeping him comfortable and raising the family. And now that he has passed, I've kind of focused more into advocacy. And so as I do more and more research and try to expose myself, I've been involved in Neil's ambassadorship as well. And I'm on the support services committee with Les Turner. I'm on an outreach community with IMALS. And I see everybody outside of the clinic and how hard they're working for us and for our community. And so I'm just amazed at the depth and breadth of our community and how everybody that's involved is all in, committed to making a difference. And I think we need some more funding. We need more drugs and trials and trial participants, and that'll help change this trajectory to slow it down and to make this a livable disease. So please don't give up hope.
I would say that I don't want people to be scared of research. I think research is like this scary thing for a lot of people in, ALS patients. You're diagnosed with this monster of a disease that nobody has quite figured out yet, right? And but I was a school social worker before all this mess, and I did not come from any kind of research background, but I just had a curiosity. And I think sometimes ALS patients feel that their only way to contribute to research is through clinical drug trials or observational studies, but there are so many different ways to contribute. Some have been mentioned today, so you could even join like the National ALS Registry and fill out surveys. You could join something like the ARC study by ALS. Sorry, you can, decide to donate your blood or fill out surveys. I even did a study earlier this year where I was sent an iPad and I had to do some fine motor activities on an iPad at home and had a family member act as a healthy control. And they're looking at technology that could potentially help track disease progression in your hands later on. So there are lots of different ways that you can contribute. Doing fundraisers, making donations, sharing your stories with med students or people in the community. There are so many different ways that you can influence people's interest in research. And yeah, don't feel like it's too much, or that it's beyond you. We can all be involved. Thank you.
Any questions, Hande?
Yes, there are a couple more questions. One of them says, during this symposium, the genetic of ALS has been covered. Is there any genetic testing at the Les Turner Center? How can we learn our mutation? What must we do? That's one question.
Okay, I can answer that. So yeah, every new patient who come to us, usually in the diagnostic workup, we do genetic testing. So every single patient should have had a genetic testing. And we get the results and we communicate the result to the patient. So if there is a patient who didn't have that done, that person could reach out to us and we can do that. We're lucky because there is sponsored testing, meaning the testing would be free for the patient.
Okay, so following up to that, they said they actually did their genetic testing somewhere else, Exact Sciences something, and then they looked at 32 genes, but they know that there are more genes involved in ALS. So do they ask if this genetic testing is comprehensive, and if the data is negative, then does it really mean it's sporadic, or what more do they need to do to look for other mutations?
Right. So 10% of ALS is hereditary. And of the 10%, we only know 60%. So there are 40% of genes out there that we don't know about. If somebody has a family history of ALS and they have a negative genetic test, yes, definitely they will need to have a whole genome sequencing to maybe discover. And it will be more helpful to do it not just in the person, but in the family as well. So having family member donate their blood will be helpful. Now, if somebody doesn't have a family history and has a negative test, it is unlikely that there is a gene there, but it still could be possible. Yes, we could add a whole genome sequence, but unfortunately, it will have to be at a cost. It's not sponsored. So it really depends on the circumstances of that person and their family history.
Wonderful. There's one more question, short.
And I would just add for that person, hold on to your testing. Make sure it's in a safe, secure spot because things are always changing. There's a chance that maybe there was inconclusive or a negative result right now, but who's to say in a couple months, a couple years? So always hold on to your testing.
Excellent. So there's one quick question. Do you think there's a relationship between type 2 diabetes and ALS?
I don't think so. I've seen patients with type 2 diabetes who tend to progress a little bit slower, but that's just an observation. I don't think that has been, I mean, patients who usually lose a lot of weight and are on the thin kind of side tend to have a faster disease progression, and patients who are a little bit overweight with type 2 diabetes progress at a lesser degree. So, but I don't know necessarily that it has been looked at in more detail.
There's no direct correlation. It's not like a metabolic syndrome, but there's some information coming out that's really being led by what happens with the type 2 diabetics. They tend to have a slower course. They tend to live longer. They tend to lose strength slower. And people are actually looking into this to see what is this protective thing about type 2 diabetes and ALS. Because on the flip side, there are certain patients who are have an increased basal metabolic rate that can't keep weight on no matter how much they eat, and they do very poorly. So there is a link. We don't fully understand it. That's probably one of the pieces of information that's led to this development of a potential treatment that is around a sphingolipids, a type of fat. So it's an important observation, but we don't know yet what's so important about it.
We're probably the only doctor who tell our patient, do not lose weight. Otherwise, we're going to put a feeding tube in you so you don't lose weight.
We prescribe cheesecake every evening. That's sort of on the script.
Yeah, I know there are some dietitians in the audience, but we had Dr. Tavi, who used to be at Northwestern and is now at National Jewish Hospital out in Colorado, give a talk on Thursday for our ALS Learning Series on complementary and alternative therapies. And she said the exact same thing. She's like, I want to prescribe the chocolate diet, the donut diet. Like, as long as you can gain weight, keep that weight on, that is really, really good. Eat the real peanut butter,
We do not want the donut diet, though.
Oh, yes, no. She was making a joke. She's like, there's a Stan's donut right across the street. It looks like Barbara has a question.
Yes.
Has there been anything between rheumatoid arthritis being inflammatory and slow progressing?
Not that we know of yet. There's been a lot more research with rheumatoid arthritis and MS, multiple sclerosis, where you have two very clear autoimmune diseases, and there's work looking at that. But so far, we don't have any evidence yet. That doesn't mean inflammation is not a part of the cascade of events that causes the motor neurons to die. Well, there are programs, though, trying to figure out what phase of the disease do you need to treat the inflammation. Maybe it's 5 months after your symptom onset to 10 months. Maybe it's a phase of the progression where you want to control inflammation to try to protect the motor neurons. So there are lots of important work being done there.
Yeah.
Hi, I'm Dr. Adaway, one of the rehab neuromuscular doctors. We talked about early diagnosis a couple of times here, and Melissa, you said you were diagnosed pretty earlier on, but Kelly, when you brought up your husband, Jason, you said that he was misdiagnosed for the first year and a half. Can you talk a little bit about the journey to the diagnosis? What are the obstacles that we face, and how can we as clinicians make that diagnostic pathway better for our patients?
It wasn't me who misdiagnosed him.
That's right. That's right. He, in 2015, actually, I didn't even notice. I think when you live with somebody and you see them, 24 hours a day, you maybe don't pick up some signs. Like, it was really my siblings that had noticed that he had some slurred speech going on. Yeah. And I was like, really? Okay. And then I mentioned it to him, and he said, yes, I have, and I've got twitching in my hand. And I said, oh, okay. So he went to his primary physician, who then said, you should see a neurologist. When saw a neurologist, he was diagnosed with focal dystonia, which, do you know
Vocal
more?
cord, maybe?
Oh, yeah. No, focal dystonia. Yeah.
Yes. And I don't know in layman's terms if
It's focal dystonia. There's nothing else
yeah,
to
just
call
like
it.
it's just a speech thing. It could come and go, or it could. Yes.
Yeah.
So, okay, thank goodness. That's what it was. And then, like a year later, his symptoms started to increase. More twitching, speech was worse again, had an MRI. I still thought it was focal dystonia. And then a few months later, it was even worse. He went back, and that physician had retired. And so the woman,
God.
yes. So the physician who took his place did the EMG testing and said, I believe you have ALS. So that was probably, about 15 to 18 month journey. And then we went to Northwestern and met with Dr. Driss, and she did her own
EMG.
review, and her own EMG, and confirmed it was ALS. So, I advocate, right? Like I didn't notice it, but then as soon as he started having symptoms, yes, we need to find out what's going on here. So
There's a few different reasons, and if you look across the board, there are a few different reasons for the variability in diagnostic delay. In my experience, the two of the fastest diagnoses I've made, the shortest time period, was because the symptoms were directly affected their work. So one was a businessman and was speaking at an international conference, and someone afterwards came up and said to him, you shouldn't have had anything to drink before your speech. And he said, I didn't. And so he landed in my office as soon as he got home. The second similar story was a sports radio announcer. And people started calling in, those sports shows where you all call in on the radio and everyone engages and the Cubs suck and, and they started saying, like, why are you drinking again? Why are you drinking on the air? And so he showed up. So both of them showed up, those two in particular, showed up specifically because it was showing up in their work. The problem we have in medicine is completely different. This scenario definitely happens, a misdiagnosis that goes on and on. Sometimes people go to non-neurologists with their symptoms. ENT, neurosurgery, orthopedic surgery being the most common, and if they have not encountered ALS in their recent practice, they will miss it for a long time. The bigger problem, the one that I have the most struggle with, is neurologists in the community who think about ALS early, but go through an entire period of time repeating testing over and over and wanting the patient to have definite ALS before they refer them on. And those people I want to shame because it's none of their business. They thought of ALS, send it to the closest center as soon as possible, let Dr. Driss do the testing and confirm the diagnosis. And I've had this done because of a misunderstanding of the LS Scorial criteria. General neurologist in the community, they have to have all the symptoms, which means that they're too late for any clinical trial before they're referred on. And those people need to get their act together and just send the patients early. Most ALS clinics now will accept an urgent referral within a week, within a couple weeks. We make space because it's so important.
Yes.
So there are different reasons. Self-referral is actually very reliable in ALS. And if you're in an area where ALS has been on the news, people have been out, self-referral is very effective. But it's those people in the community who are colleagues, but they're misusing their position by not referring on.
I'd love to plug one of the posters this afternoon, and I think, Dr. Driss, you were an author on it, that looked at the financial burden.
Ali's poster, actually, she's right there.
Yeah, the financial burden of misdiagnoses, delayed diagnoses. So very nice job. And very pertinent. We need that information.
Yeah, it costs money. It costs money and it costs time and it costs a lot of things. Yep.
And it costs, oh, go ahead, Dr. Wolf. Sorry about that.
Yes, please.
And Angela, this is an American problem. Many of our patients are insured under schemes in which they have to stay within a specific hospital to receive services. Oh, you want me to do that? Okay. Okay. Many people, because of their insurance schemes, be they private, Medicare Advantage, any of those kinds of things, have to stay within a specific hospital or hospital system. And if that system doesn't have an ALS program, the local neurologist is actually incentivized to keep the patient. And that is something that I actually think is much more nefarious than what you're talking about. But it's an American problem.
It's too bad that wasn't put in as part of the Act for ALS, because they could have created a pathway. Maybe when they get over whatever happens tomorrow, they can get back on it, because it's having a huge effect. It's having a huge effect. In Canada, it's really about people who've been in practice for a while. They don't want the embarrassment of sending someone with a diagnosis of ALS, but it's not. I much prefer to do that than have someone hang on to a patient for a year and a half before they're 100% sure and then send them on. That's just wrong. So I understand. Tell your congressman.
We'll work on it.
One year, I mean, once a year we do the CME for the neurologist. He's in the whole system.
Yeah.
And I told them, I promise you, if you send me somebody that's not ALS, I'll call you and thank you. I mean, do that.
Yeah, no, absolutely.
So I've been pushing for that. Don't worry, just let me figure it out.
Yeah.
Just send it. So I've been pushing for that.
I can't do anything about neurosurgeons, I'm just saying that.
Thank you all so much.
Should we ask the audience if there is any more question?
Oh, is there,
Any more questions?
Joe, do you want to, yeah.
Thank you all for being here. Kelly and Melissa especially, thank you for sharing your stories. I wanted to address what was mentioned several times about early diagnosis. And Dr. Driss, please correct me if I'm wrong, but my mom's situation, she was a very slow progressor, and it took at least 2 years to get down here.
Yeah.
And my problem with that is, and something that I'm trying to work on now is, when you have drop foot or you're falling or you don't know what's going on and your family doesn't know what's going on, you go to your primary care doctor or you show up at an urgent care or whatever. Those folks don't know, they don't know. And family members don't know. I'm embarrassed to say, had I known to recognize that foot drop, damn it, she would have been there to see you earlier, Dr. Driss. But my question, I guess, being, as the ALS community, part of the community, what can we do to educate? You know, there's no drug company that's going to send out sales reps to internal medicine. How do we do it? How can parts of the ALS community make a difference in educating those frontline providers that people are showing up to see, and they don't know what they're looking at?
Yeah, that's a very good question. I don't know what the ALS community could do more than actually raising awareness, which you guys are doing a good job at it. But I can tell you that we are trying to make sure our medical students do not leave medical school without at least have been exposed to it and saw it. I mean, a lot of our medical students do rotate through not all, but many of them do rotate through the ALS clinic. So we're trying to do that, and that's how we get physicians that have at least seen it at least once and can think of it and recognize it.
Can I just, sorry. And then the other shout out in terms of internal medicine, we have a dedicated service on the 11 East floor here where every one of the residents as part of internal medicine has to rotate through, and all of our ALS patients are cohorted on that floor. We did that because it actually provides better care for ALS patients. But the upside is every medicine resident that graduates from here has seen what ALS is. They've helped them get a G-tube. They've helped them start their NIV. And it's been a good secondary outcome of all of that.
Yeah.
So one of the problems, which is not surprising to anyone here, is that ALS patients feel well. Cancer, you feel sick, so you're very persistent. ALS patients come and they say, well, all the tests, the doc says, well, your tests are normal, because they haven't done an EMG or something, right? One of my best lessons ever is a patient I diagnosed at a cocktail party. Not because the patient was at the cocktail party, but the daughter came and said, my dad's getting weak and it's been a year and every test is normal, so who should see him? And it was, one of these random conversations. I said, me, and bring him on Monday. And he was a chicken farmer and a hardcore, hardworking guy who was just losing his ability, but the tests were normal and he didn't feel sick. So the connection between having something very serious where you don't feel sick is a really difficult thing in your head. So that's a part of what we get out there. It's really important.
Or like Melissa said, just those daily life stressors. Do you want to talk a little bit more?
Yeah, I just want to, my mic is back on. Hey.
Yes, sir.
Well, the gentleman in the back, I didn't catch your name, but
Joe?
I think you made a good point. As somebody living with ALS, I am terrified whenever I have to go into a medical setting that is not the ALS clinic. Because I can't tell you the amount of times I've had to go to the emergency room, the gynecologist, I had to get an MRI recently. And I mean, recently they literally said to me, we're trying to figure out what to do with you, in a medical setting, right? So even within medical settings, sometimes they haven't heard about ALS. They know very little about it. So sometimes as patients, we have to be the educators on this very complex disease. And not everybody feels equipped to do that. And you're also in a place where, okay, you just fell, your head's bleeding, you're trying to stay calm. Now you're trying to, educate this medical professional on your disease so that they don't harm you further, right? So it is a lot of pressure. So I'm glad to hear that medical students are, this is a priority. And I hope that this is why I think sharing our stories within the medical community is very, very important. Yeah.
Oh, yes.
Hi. Hello, I'm Dave. I'm a caregiver for my girlfriend who was diagnosed 6 months ago, and she's a patient here at Northwest. I'm gonna sound ignorant, and I hope I'm not insulting, but it feels like there's a disconnect between the excellent clinical approach here and functional medicine and some things that can help patients from not eating donuts so they get enough calories, but changing their diet and getting better water and air, checking for microtoxins and metals. And I know it's a scatter plot, and it can be kind of a clown car thing at some point, but it seems to me I've found that there's a fair percentage of people that do respond to some of these intelligent changes. And I'm trying to find a functional medicine doctor who knows something about ALS, who's not it's 600 miles away, and I haven't found one, which is weird. But Northwestern doesn't really address that, and it feels to me, and I haven't figured out. I mean, I know there's a lot of research, and there's a benefit for research and pharmaceuticals and all that, but maybe there's no money here. I don't. Like I said, I'm ignorant, and I don't want to be insulting. But is there any way to match that up a little better?
It's a good question, and I'm sure it's a question every single patient asks our dietitian. And I wish we could prescribe a specific ALS diet. However, there were diets that were studied, but the number of patients is small, and it's very difficult to say, okay, like we're gonna use this like we do with our clinical trial. So yes, maybe that's what we need, more research in specific diets to see what kind of nutrient will be more important than other. I mean, I wish I have a better answer than just keep your weight on.
Yeah, and I would also highly encourage alsuntangled.com is a phenomenal resource for anybody who's looking into kind of off-label treatments or supplemental treatments. They take it from a very scientific background, they review the research that's been done, and they actually give you a rating scale of how beneficial it would be for somebody living with ALS. I would also highly encourage you, if you haven't had a chance to check it out, but like I said, last Thursday, it's up on our website. Dr. Tavi gave a wonderful 1 hour long webinar on complementary and alternative therapies for people living with ALS, and talks a lot about acupuncture, different diets, different supplements, what's known to work, what's kind of not worth the money, because oftentimes too, a lot of what's out there costs an exorbitant amount of money for an already very expensive disease. So I would highly encourage you to check that out, definitely.
What you're bringing up, though, and you don't even realize you're bringing it up, but I'm going to put it out there, is the question that has dogged the field for as long as I've been in it, is whether there's something environmentally that triggers the disease, which you didn't ask, but I'm going to answer because it's important. There are clearly some things in the environment, and there's some environment genetic interactions. We don't fully understand them. We know that there's certain things about American football that has an issue, which we think is related to head trauma or whiplash. There's a very old story about organic pesticides that has never fully been resolved. And there's a relatively new story about blue-green algae in the Northeast, and whether that can be a trigger for a reason for clusters. I had the conversation with Dr. Rouleau just a couple weeks ago. It's very possible that these are real observations. We just don't understand them yet. But that doesn't mean no one is looking. And if there is a concern about your water supply or there's something like that that's in your environment, absolutely make those corrections. Read Untangled. I think that's a good reference. Look at your diet. We like the Mediterranean diet with red wine and coffee, just saying, and cheesecake. On a bad day, a cannoli, that's where you go. But there is something out there that we will eventually understand, but we don't understand yet.
And joining the National ALS Registry, they have a specific survey that looks at environment and all the different places somebody has lived, not just where they currently live. University of Michigan, Dr. Dick Goutman is doing some really incredible work at looking at the environment and environmental factors.
It's called it's called now the exposome. Like we talk about the genome, it's the exposome. It's the thing we're exposed to. So it's a very active area of research.
And then I'm so sorry to keep throwing this stuff out. The only other thing is that if you know someone who is a veteran, even if they have not received veteran benefits in the past, because of exposures in the military, the PACT Act now requires that any veteran with ALS automatically become 100% VA certified, and we can work together with the VA doctors to get them anything they need. So it's just one other thing we're thinking about.
All right, we've gone way over time, and Telly is going to
Yeah.
fire me. So I want to thank everybody for their questions, our panelists for your insight. I think this was a beautiful example of how much we can really all learn from one another. So from the bottom of my heart and the entire foundation, thank you all so much for your time. I'm going to now throw it over to Dr. Kalb for closing remarks. Dr. And
Okay.
thank you for spending your special day with us.
Hi.
Dr. Kalb is the Joan and Paul Rubischlager Professor of Neurology. He is chief of the Neuromuscular Disease, and he is also director of the Les Turner ALS Center at Northwestern Medicine. Dr. Kalb?
Hi. I just want to start with the thank yous. Want to acknowledge the contributions of Mitsubishi Tanabe Pharma, Amylyx, NewMotion, Biogen, Unicure, and the people that actually made this event occur, starting with Telly Walker. Where is she? There she is. Let's. As well as several other people on the planning committee, Ashley Rosenbach, Hande, Lauren, Mark, and Riley. Also the information technology team, Josh, Mark, Michael, and Isa. And, you know, it's a tough situation. It's a tough disease, and you just need to go long here. It's like a marathon, and you have to be willing to tolerate pain and suffering and disappointments along the way, but there is an answer. I'm a stubborn optimist. I hope all of you are as well. Thank you.